the New York State marketplace. Next screen. And then there's 4 of the metal tiers that are offered in the marketplace for the qualified health plan. There are bronze, silver, gold, and platinum. Bronze has the lowest premiums, but it has the highest out-of-pocket expenses. Platinum has the highest premiums, but the lowest out-of-pocket expenses. So it's based on what the need of the individual is when they meet with the in-person assistant. Next screen. Now there's 2 forms of financial assistance that are available for individuals and families. There are the tax credits, which may reduce the monthly premiums, or the cost-sharing credits, which can lower the co-pays and deductibles. It all depends on the household composition and the annual income that's in the household, which will determine if the family is eligible to receive financial assistance to go towards a qualified health plan. Next screen. As a navigator, when we assist individuals with applying for health insurance, we want to make sure that they choose a plan that's right for them. So we often encourage them to inform them to consider the premiums, out-of-pocket expense, financial assistance, provider network, and the drug formulary list. When the navigator goes over all of these items, the individual is more comfortable and can make a decision that will best meet their family and a decision that they can actually afford for their household. Next screen. How can an individual enroll? There's 3 options. An individual can meet with the in-person assister. They can contact the customer service center, or they can actually go on the New York State of Health website to apply for health insurance. Individuals can contact the customer service to find a navigator located in their area, or they can visit the New York State of Health website to locate a navigator in the area. Next screen, please. Additional resources, next screen. On the New York State of Health website, they have a lot of resources for individuals to help them make the decision on the health plan and just basically just understanding what the marketplace is all about. This is a new informational video they have regarding the renewal coverage. Since this is the first year for individuals to renew, it's a video that actually explains the renewal, what the process is, and how that individual can ensure that they have coverage for the following year. Next screen. There's also a tax credit and premium estimator, which is available on the website. And this allows the individual just to go in and indicate their household composition as well as their income to determine if they're eligible to receive financial assistance, and if so, an estimation of what their premium costs may be. And we often encourage individuals to visit the website and look at that estimator so they can just get a general idea of what they can expect. But we also encourage that they come in and meet with the in-person navigator so that navigator can go over the health plans with them, as well as look up their doctors to ensure their doctors will accept the plan of their choice. The website also has a new Spanish website within the New York State of Health website, so they're starting to expand it in other languages. And they also have an interactive events calendar, which lets the consumer know events that are taking place throughout New York State. And also they have what they call, now that you're covered, how do you use your health insurance? And we encourage individuals, once they sign up for health insurance, to use this information. Many times we will print it and give it to the individual, as many do not have access to a computer. So we ensure that those individuals do receive something on how to use their insurance. We find that many individuals that have enrolled are new to having health insurance. They don't know about health insurance. They have not had it before, so they're not understanding the use of the insurance cards, how to find a provider, when they go to the doctor, where the insurance cards. So this kind of guides them and helps them to ensure that they know what to do when they receive their card, how to use it, how to find a doctor, and to ensure that they stay on top of their health needs. Next screen. If individuals need to meet with a in-person navigator, they can call our organization or they can contact the New York State of Health website. Our navigators are located in Monroe and Livingston County. And we have approximately about 15 in-kind sites throughout the area where individuals can meet in the area that's closest to their neighborhood. And one of our partners is with St. Joseph's Neighborhood Center. We have a navigator at their location that deals with their clientele and assists with individuals enrolled in health insurance. But I do encourage individuals to meet with the navigator. This is a process you don't have to do alone. This is a process you don't have to try to figure out what kind of health plan. The navigator is there to help you with the process. They're there to advocate on your behalf and provide education what the Affordable Care Act is and help you make a decision that will be in the best interest for you and your family. Thank you.
Good evening, everybody. So I am here, and as I'm listening to both Sarah and Kim, I will be blending some of the information that they've said and kind of translating those facts and figures into the impact on individual lives of being uninsured, having the affordable health care available to them, and what the impact has been now through the first quarter of 2015. My remarks actually come with the story of being an organization, as Sarah had said, that has provided primary health care, mental health counseling, and other services for over 20 years to those who lack insurance and lack access to primary care services. As you well know, having insurance and having access to health care are two different things. So we have to kind of keep that in mind. The implementation of the Affordable Care Act and its various provisions and goals was something we looked at with great interest at the Neighborhood Center. I have a couple of my providers in the audience here, and they will remember back in 2012, 2013, and a little previous to that, that we were almost going to implode because the request for our services was so overwhelming. And what we did was close down for 8 weeks to new patients. Absolutely killed us. Because no is just not in our vocabulary. So to have people call for 8 weeks and ask for an appointment and we had to say no to them was just, it was terrible. But our goal in that 8 weeks was to better serve the people who were calling us for services in terms of triaging them for eligibility for any public service, any public insurance product that was out there on a state level. And also there's something called 330B money, which goes to, which is federal money. So we schooled ourselves very well. This is prior to the rollout in 2013 of the individual mandate. So we had put into play a system where we could actually help people. As I said, we prepared for that so that our patients and clients would be somewhat ready for the impact of the Affordable Care Act and how it was going to roll out for them and what influence it was going to have on their lives. As Sarah mentioned, the ACA was signed into law in 2010, but the individual mandate didn't come until 3 years later in 2013. So we had some time to prepare, and we're very glad we did because, as both Kim and Sarah had said, the lack of education and understanding about what the Affordable Care Act is and what it's intended to do still is woefully inadequate, not just here in Monroe County or New York State, but across the country. We knew two things. We knew that individuals would be impacted by the provisions of the law. And at that point, we had around 1,500 patients or clients, those in primary health care or mental health counseling. We also knew that given the global aims of the bill, and that is what's called the triple aim that Sarah mentioned, which is to improve quality, decrease cost, and improve access to health care. Given the global aims of the bill, that there was now the potential for positive impact on the larger dysfunctional system of healthcare that we all have been living with for years. But it couldn't be a bill that was going to be enacted in a year or two. That kind of global vision has to have a long period of time of rollout and a long period of time to be able to evaluate the impact of the initiatives that are being taken. So what do we know 5 years in? Here we are, 2015. That hardly seems possible. I brought just a few slides tonight. The first two will give you a snapshot of who we are currently seeing as patients and clients at St. Joseph's. From 20, I think I've got, well, this is March 2015, but some of the slides will be from the rollout 2013 through the first quarter of 2015. And I have a new toy. Oh, you probably can't see it. And this, like Sarah's, didn't come out in the colors that I wanted. So, right here in the 41 to 60 age group, you can see that about 60% of the people we're seeing are between 41 and 60. If you add in the 31, to 40, it goes well over 70, 75%. There's reasons for this. The 0 to 18 and the 19 to 30, first of all, in New York State, there's no reason for a child not to be covered by health insurance with Child Health Plus. So we see children, but as we're seeing children, we simultaneously meet with their parents to get them hooked up or re-hooked up with CHIP. The other thing in that age category of 0 to 30 are the group we call the young invincibles. Those are folks who don't, right or wrongly, don't need to see a doctor or don't feel they need to see a doctor, so we don't see them. They are invisible to us. They are invisible to the health systems agency that plans for health care. And that's a concern, because some of those folks, all of them sometimes, are going to need health care. But if they're invisible to us right now, we can't plan for that kind of health care. On the other end of the spectrum, the 61 to 65, I'm gonna be 64 in a couple of weeks, and they've already started sending me like Medicare packages. So, yeah, so plan for your Medicare. But that group is a group, if we have somebody that's that age, we start aging them in or getting them ready for the idea of Medicare and the Medicare options that they have. So for lots of reasons, it makes sense that our largest population is right in here. But we'll also say, look at over here, don't pay attention to those numbers there, but those numbers do indicate that most of these folks are in the 10 to $25,000 annual income range. So some of them do, or some of them don't qualify for whatever reasons for the Medicaid or the marketplace. They're the working poor. They are the group that we have been taking care of for 20 years. They may have a full-time job, they may have 3 part-time jobs, but they're the working poor for whom this whole idea of insurance is a problem. This is just some patient appointment trends, and it's 2012 to 2014, and then the first quarter of of 2015. And we'll just look at the totals down here. You can see it in 2012 we had over almost 14,500 visits. For the neighborhood center, that's probably about half the actual people we serve. We have another whole population that just comes in for kind of everyday services. These are people that are registered with us as patients and clients and have a formal primary care relationship with us. You will see that for all of 2013, the number really didn't change that much, about 300-400 people. But there's a big change between 2013 and 2014. There were 1,780 fewer appointments that we had. That is a direct result of the first open enrollment period of the ACA. But you will see that I have put the first quarter of 2015 in there, and if I actually push that out, we're only about 500 off target to actually match 2014. So what we're finding on the very practical level is that the number of appointments and number of patients went down as a result of the first and second open enrollment periods, and now, as we predicted, that number is starting to go up again, as people are dealing with different facets of it. Next slide, please. Some short-term impacts that we're finding of the Affordable Care Act. For 2010, and you'll recognize some of these, from 2010 to 2013 and on, the first quiet rollout of the ACA allowed children to stay on their parents' insurance until they were 26. Pre-existing conditions could not be considered in coverage decisions by insurers. Medicaid eligibility expansion, as Sarah illuminated, in states that adopted the option, came greatly into play for people. Also, there were lifetime benefit limits were taken away. They were taken off the table, so you can't say, sorry, you used up all your money. That can't be true anymore. And preventive services like mammograms and scans and all that kind of stuff are required to be covered at no cost by the insurers. Next slide. Just some information, and I think Sarah touched on this, the rollout, but listen to this as it affects actual individuals and actual families. The first rollout of the healthcare exchange was for 6 months. And it was October 2013 to March 2014. I think actually it wasn't exactly going to be 6 months, but it was expanded towards the end of it. Just like now, we're just ending the second version of the open enrollment period. And that was, November of 2014, I think originally into March, and then it got extended to April 15th, and now it's extended to April 30th. So, there has been wiggle room and response from the state about what we really need to do, and these deadlines, which in some ways may be proving a little false in terms of a deadline. And again, that subsidies are important that were offered to assist affordability, incentivizing people that they could get subsidies towards their premium. But the other kind of negative incentive was that if you don't do either enroll or prove that you have health insurance, you're going to get dinged. And I'll give you, just in case you don't know, I'll give you what the 3-year ding factor is. So people who had insurance or did not have insurance in 2014 are reconciling, as we all are, our 2014 taxes now in 2015. For those who can't prove that they had health insurance in 2014, the levy is $95 per person per household, or 1% of your income, annual income, depending on which is greater. In 2016, when people's 2015 taxes are reconciled, the fee will be, or the fine will be rather, $325 per person per household, or 2% of your annual income, whichever is greater. In 2017, when we reconcile 2016 taxes, it's $695 per person, per household. So that you see the incentive to actually always do the cost-benefit analysis between what's affordable and what is it going to cost you in fees is very, very important to do. And that's one of the services we provide to people. What is it actually going to cost you to do this?
Annual or monthly that you're talking about?
It's annual. Annual, yeah. Qualified health plans for exchanges. I just want to say a little bit about qualified health plans. Kim mentioned them, and then you saw a list of what health plans needed to cover. There are 10 pieces of the there are 10 qualifiers that every health plan that gets qualified on the exchange must meet, and that was that list that Kim read you. So a qualified health plan is a plan that has been vetted by the federal government and the state to make sure that they meet the minimum requirement according to federal guidelines. A little sidebar for me, I always have to say it, is apparently adult oral health is not essential because it's not one of the minimum standards, nor are adult eyes or ears. So anything from here up is not essential. To be helpful. Okay, next slide, please. And again, we've touched on some of these. Okay, here we go. Medicaid expanded to 138% of the federal poverty limit, increased eligibility for many people. And that's 138% up to 200%. Next year, there's going to be introduced something called the Basic Health Plan, which will cover the people from 138 to 200%. I'm sorry, Medicaid goes up to 138. There was that gap. This Basic Health Plan basically replaces Family Health Plus, which disappeared. And in some instances, the Basic Health Plan will be not only affordable, there will be no cost to it. So we're looking forward. And the only two states that's rolling out is New York State and Minnesota. I don't know why this is true. There's two states, because we're allowing it to happen. The working poor now had options for a qualified health plan that was affordable, and I've just explained what a qualified health plan is. There's some rigor to actually being able to be on the exchange as a plan. The uninsured population remains. Some are ineligible, and some qualified health plans continue to be unaffordable despite the subsidies, and people are finding they have to make the decision to remain uninsured. What's happened with the rollout is that we have a whole new cohort of the population that has been created. These are people who have insurance they can't afford to use. They're paying the deductible, they're paying the premium, they're paying the copay. They might go see their primary care provider because they can afford $20 or $25 for that visit. But many of these folks cannot afford specialty visits nor frequently recurring visits like mental health, physical therapy, chiropractic, those things that you really need to do repeatedly in order to get the health benefit that they would offer you. And they can't afford those because those are $40 or $50 maybe a shot, and if you have to go once a week or to PT, you're supposed to go twice a week, that's unaffordable. So people are paying for insurance that they can't afford to use completely. What we have also discovered, and I know Kim has got many stories about this, is discrepancies in the rules governing eligibility that have been uncovered, and some are being fixed. Just unintended consequences of some of the rules and who, let's say, in a particular family was eligible for an employer benefit as a single, but the family benefit was way too expensive. So, the family had to make the decision, are we going to pay that family premium, et cetera, or are we just going to go with, let's say it's just the dad being insured. If it was just the single spouse being insured by the employer, the rest of the family was not eligible for a subsidy on the exchange. We just think that's way wrong. We have a lot of anecdotal stories pointing that out. and along with other things, where the rules and regulations, just unintended consequences, have made a burden and made it burdensome on some people. My last slide, indications are that costs are coming down. New York State and the New York State department that heads the marketplace does take input from the community. Sometimes they haven't liked our input, but they've had to take it anyway, about the problems with implementation and that they're burdensome and creating barriers. We desperately need better education about the New York State marketplace and about the whole ACA, in general. Probably some of you saw last year the Jimmy Fallon interview on the street, where person after person said, "I hate the Affordable Care Act, but I love Obamacare." And would not hear that they are the same thing. Just would not hear. We had one woman come in, and our navigator from CCSI, she actually got her down to a $40 a month premium. And the woman said, I'm not taking that, because I know I can go someplace else and get Obamacare for free. And she left, and we never saw her again. And that's just a crime of confusion about this. And I have to say, for the extent of the bill, it really is too early to know the long-term impact on healthcare cost, quality, and access that are intended by the ACA, because we've only got 4 really years of data. We're looking to have 8 or 9 years of data to actually measure impact. So it's, we can say that we can name the short-term barriers and burdens that have been created, and we'll try to fix those. But right now, we really can't pass very good judgment on what the long-term impact of it is.
Are the indications that costs are coming down referring to medical costs in general, or consumer costs?
Medical costs. There was at the first blush of people signing up for their health insurance, whether it was Medicaid or a qualified health plan. People who hadn't gotten health care in a long time got to their PCP and got all kinds of stuff done. So initially, probably if we saw a curve, we would see some upward movement. Now that it's starting to flatten out, people have gotten to a state of health or some kind of stability. That big push of a lot of people entering the healthcare system with insurance is kind of over. It's going to be steadier, and we'll see the costs going down. But initially, there was a great use of healthcare, which is wonderful. So, thank you.
I'm between you and the question time, so I'm going to try to be, and I have no slides, so you don't have to worry about that. I'm going to talk a little bit about the court challenges, because as Sarah told you, this was controversial. And when things are controversial, what do people do? They sue. And that's precisely what happened. And the first challenge was a facial constitutional challenge. And the National Federation of Independent Businesses, the group that represents small businesses, brought a facial constitutional challenge. Lower court split on whether the act was constitutional or it wasn't constitutional. And it made it to the Supreme Court, and the Supreme Court ultimately basically fractured with 4 votes on one side, 4 votes on another side, and 1 vote, the Chief Justice, in the middle. And for those who kind of watched the work of the court, it was very obvious reading the 3 opinions that the lead opinion by the conservative justices was written as a majority opinion. It had the structure that a majority opinion has. And at the last minute, the Chief Justice walked away from the opinion, at least that's what most court watchers believe. The opinion by Justice Sotomayor, which was the main opinion for the centrists on the court, was structured in the classic structure of the dissent, and yet it ended up carrying the day on some of the issues in the case. What ended up happening was the act was declared to be constitutional because that penalty was a tax. So Congress had taxing power, not the general welfare power to do this. And the price that was paid for it was the mandate for Medicaid expansion. Because the Chief Justice said, oh, no, the states are sovereign. We can't coerce the states to expand Medicaid. Now, we expanded Medicaid on the states dozens of times, and sometimes by, multi-million-dollar kinds of expansions, and it was all okay, but not anymore. And the Chief Justice said no, and so what you had was state option to expand, and you saw the map of which states have picked it up and which states haven't, and that has a lot to do with who are the governors and who controls the legislature in those states. Now we have a new challenge, and those of you who've been following the news have been seeing the King against Burwell case that is currently pending in New York. The good news for those of us here in New York is it doesn't matter to us. We have a state exchange, and the issue in King against Burwell is, can subsidies be paid in states that use the federal exchange? Because the language of the act says that subsidies can be paid in states under Section 1311. Well, Section 1311 says every state shall have an exchange. And then there's another provision, I think 1315 or so, that says, but if the state doesn't have one, the feds can step in and set one up. So there is now there's been oral argument in the case, and most court watchers think that there are 4 firm votes to uphold the subsidies for the federal exchanges. There are 3 definite votes not to, and then the Chief Justice and Justice Kennedy, for different reasons, maybe the swing vote. Justice Kennedy may vote with to uphold because he believes, or his questioning suggests that perhaps he believes, because of course the questioning is not, the final place where the judges come down, but the questioning suggests that he may believe that that it would be overly coercive on the states to say to them, your citizens don't get a subsidy if you don't have an exchange, and that would be kind of gun at the head duress. There are 8.2 million people who live in those states with federal exchanges, and some of those people could get madder than hell, and they're not going to take it anymore, and they might take it out on their legislators if those went away. And so Justice Kennedy seems to be a little worried about that. And the Chief Justice was very silent during the oral arguments. We don't, have a lot of sense about what he's thinking about. So stay tuned. We will all see. But this does matter. It matters a lot to the 8.2 million people. And today we were on Evan Dawson's